So, welcome everybody. It's Tuesday afternoon, which means it's time for my live, unedited, unscripted show where I interview patients like my dear friend Sunita Puri, doctors and other thinkers about the inseparability of mental and physical health, about practical ways to improve your health, given that most people have 5 minutes with their doctor if they're lucky enough to have a doctor to begin with. I'm going to introduce Sunita and then I'll let her introduce herself. She's one of my favorite people,
Yeah.
and it's very, 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 very special to me personally. I'll talk about that in a minute. Um, Sunita is an associate professor of medicine at UC, University of California, Irvine, where she's the director of the Inpatient Palliative Care Service. She's also an extremely accomplished writer and author. Her book, That Good Night, Life and Medicine in the 11th Hour, I will link in the show notes, is an exceptionally moving book. It's about how to frame living in order to frame your dying. It's hard to even put into words what it's about, but that's what we're going to talk about today. Today we're going to talk about, is it possible to have a good death? Is it possible to orchestrate your death plan like people do their birth plans? What are some practical piece of advice you have for people who are either at the end of their life or thinking about someday being at the end of their life? She's a dear friend, and importantly to me, she was one of the last people I spoke to last July when I lost my baby brother suddenly in a car accident. And we were talking about death that day. We were talking about meaning and purpose and spirituality, and we were talking about death. And then my brother went and died. And it wasn't a coincidence to me, Sunita, that you and I had spoken. And you have been a support, whether it's been in person or just online talking to me. Like on text. And so I just thank you for that. And I'm just so glad you're here today to talk with my audience.
I'm so glad to be here too. This is a real treat, and what you put out into the world is incredibly important. We're living at a time where information about medicine and health is more compromised than ever. So to have this space where you're giving real information grounded in science to people is just it's a public service.
Well, thank you, Sunita. I think that one of the best things we can offer our patients is honest, human conversations about what people are alive for.
Yeah.
So when that doesn't always come into play when I'm talking about should you take Advil or Tylenol for your, headache. But when we're talking about big decisions, whether or not to take another round of chemotherapy for your advanced cancer, whether or not to have surgery or not for some terminal illness, whether or not to, you know, go full court press, medicalize the end of your life, or alternatively, choose more comfort, palliative care, there are not enough people in this country, not enough people in medicine who are able to have the kind of conversations that you are able to have with your patients. Not just because there are not enough palliative care doctors, but because we aren't trained as doctors necessarily to have those conversations. And also because our system is designed to medicalize dying, to treat people at the 11th hour with the most aggressive treatment. So what I want to talk with you today, Sunita, is about how you conceptualize a good death. Is a good death possible? And how you message that, how you communicate that to your patients and to this audience here. I've got 35,000 subscribers here who, I think are really interested in what you have to say about, is it possible to have a good death?
Yeah. So you said so many important things that I think are key to helping people have a good death. And I want to take us back in history just for a moment,
Please.
because centuries ago, there was a booklet distributed throughout Europe called Ars Moriendi, which means the art of dying. And there were specific instructions, much of them grounded in religion, about how you could help a loved one achieve a good death or how you could achieve a good death yourself. And a lot of it had to do with support from other people around you, making peace with God, Those sorts of things. So this idea of what it means to die well has been around in a long time for a long time, not just in European settings, but in really ancient traditions in India, for example. So Hinduism and Buddhism meditate a lot on the idea of impermanence. The fact that if you can't get used to the fact that change governs life, you're in for a lot of suffering because you're resisting what is. And that transcends, the experience of death and dying. But nonetheless, civilizations, religious traditions have contemplated this for a long time. And in the 70s, when you saw this big explosion of improved medical technologies, in the 60s, we had the iron lung, we had CPR invented. Medicine became a lot about extending life at all costs, regardless of its quality. And that was when, for example, the hospice movement arose, the quote unquote right to die movement arose, meaning that people had strong opinions about whether they would want their death extended by modern technology or whether there was another way. And so that was a time period in America's history where these conversations started to come to the surface. And I say all of that because I think sometimes we take for granted that we have certain rights now, that we have the right to document our wishes and they will be, accepted or at least seriously explored. We have the right to say, no, I don't want a ventilator. I don't want CPR. Back in the 70s, a lot of doctors and hospital systems, and quite frankly, the legal system, equated that to homicide. So when we think about a good death, we have to put it into this historical context, in my opinion. And I think the idea of a good death has become slightly problematic because I think when most of us think of what a good death is, we think of it being at home, surrounded by friends and family, being comfortable, controlling the situation. When so much of life, whether it's a birth plan or a death plan, is ultimately out of our control because we don't actually know how our bodies are going to experience dying. And so I've had patients whose families are really wedded to this singular idea of what a good death looks like.
Mm.
But in reality, either A, they may not have, quite frankly, the financial or economic resources to help a loved one have a good death at home, because hospice doesn't provide caregivers, for example, and hospice isn't around all the time. So people often have to make that investment, which is hard for people. I see people who are on ventilators in the ICU, and I have to comfort family members who feel like they failed their loved one because they couldn't take him home. And I'm of the belief that people can have a good death in the ICU. People can
Mm.
have a good death in the hospital or a nursing home. It doesn't have to be this gauzy image of a perfect death at home. And if that doesn't happen, it doesn't mean that it wasn't wanted or that people didn't strive for that. But just like in birth, you don't know what's going to happen. And just like in death, you don't know what's going to happen. So I think kind of is calling softening the rigidity of kind of our conception of
Mhm.
what a good death is really helps make it more accessible to people. And it helps take into account the context of people's lives, which is ultimately what we're trying to do in medicine and certainly in palliative care, is know the person, know what their life is like and what's important to them. And I've sometimes been the one to say, I can't send you home because A, you're too medically unstable, and B, if you got home, I think your family, quite honestly, would be too overwhelmed to take care of you. And people appreciate that honesty, going back to what you were saying.
Yeah, you and I were talking last night or 2 nights ago on the phone about, you know, the idea of shared decision making is, of course, paramount, tantamount in medicine, right? Like, giving people options, helping them understand benefit and risk. For example, the benefit of this chemotherapeutic drug is that maybe it would extend life for 3 more months. The downside is extreme nausea and, other unpleasant side effects that may make those 3 months not worth living. It's also an act of love, I believe, and sometimes I can say I love my patients,
Yeah.
to render an opinion. And you tell them it's an opinion, but in my opinion, I would recommend this, especially in a death and dying situation. I think I think to withhold an opinion when you are an expert, not in death, but in the understanding of risk benefit, the understanding of
Yeah.
trade-offs, and in medical, conditions, is to deprive people of a little bit of to deprive people of some guidance, right?
Yep.
Because so so I want to go back to what you said earlier, Sunita, that it's possible to have a good death in a hospital, in a nursing home, and that the financial resources required to have sometimes these idyllic deaths at home surrounded by loved ones is not realistic for most people. And
Yep.
you're right. People are often surprised when I engage hospice, and I tell them this, but the hospice doesn't send an army of people. It doesn't send. I mean, hospice is a wonderful, wonderful organization. It's finally covered by Medicare. That happened a while ago. And hospice, but it isn't 24-hour care. It doesn't provide that kind of service. It's more of a framework.
Yep.
Can you describe? So actually, I'm going to answer. I want to go back to what I was asking you earlier. It's possible to have a good death in the hospital. It's possible to have a good death in a nursing home. And I think what you're saying is that it's important to recognize that because people have these visions of what death is going to look like, sort of like they
Yep.
had a vision of, giving birth to their first child with, music playing softly in the background and, their best friend sitting next to them and, they end up having an emergency C-section on the
Yep.
highway, right? Or giving birth in the back of a lift or something. So why does that matter so much? Because do you think that when you talk to your patients, do you think that the majority of people think needs to be at home or that there's some downside of being in the hospital? Can you flesh that out a little bit?
So I will say that for some of the very sick people I see, and to be honest, I only work in the hospital, and a lot of the people I see are very close to the end of life. And
Yeah.
so families are generally overwhelmed. And I'm very honest with them about what hospice is and what it provides and how it's really a sister specialty of palliative care. So it's getting the support we're giving them with the interdisciplinary team. But I explore pretty explicitly, how do you feel about being the one to give him morphine if he gets short of breath?
You're talking
How do
about
you
the family member, the loved one at home. Mhm.
'Cause they don't know that. 90% of people don't know they're gonna be responsible for the type of care that professionals have been giving for a long time. They may have been helping with giving pain meds at home, but when it gets to the point of being very close to the end of life, I've had people call me. I do bereavement calls, like follow-up calls after someone dies, and some people said, "I gave him morphine and he died a half hour later," and they really wonder if it was their action. And I always have to say, it is not you, it is the underlying disease. All you were doing was keeping his suffering minimal. So you were exerting mercy in the face of a merciless disease.
Mm.
But I think also, so that's one aspect of it. I think, again, people who don't have some of the resources that other people do prefer their loved one to die in the hospital because they're like, you guys know what you're doing. We don't. And then it becomes a discussion. I mean, there's always pressure to discharge patients coming from above. So then it becomes a discussion of where can we realistically do this? And I think I want to go back again to this concept of being honest because they can't make good decisions if they're not informed. And I think I want to expand on that in a moment because I think that's really where we fail our patients.
I mean, I want you to scream it from the hilltops because I think
Yeah.
there is an honesty element here that we need to touch on. So please
Yep.
go ahead.
So I wrote a piece for the New Yorker on CPR, and I'm just going to use CPR as emblematic of the larger problem.
Right.
When I was a resident, I asked people, if your heart stops, do you want me to do CPR? And I would explain CPR as like I'd use the hand motions, like, we have to mash on your chest and it can be really uncomfortable. We can break ribs, but we're trying to like save your life. Some ridiculous thing like that. I was never taught how to talk about CPR. I was never really taught communication. And I was trained at a place with an outstanding palliative care program. And it was just absent from our curriculum. So, how did I learn? I mimicked my senior residents, I mimicked my attendings. And I, because I didn't know how to talk about CPR and be honest about it, I think I caused a lot of suffering, unnecessary suffering, because I was not putting it in the context of what someone was going through. So, as an example, if your partner suddenly turned to you and said, I think we need to break up, out of the clear blue sky versus I think we need to break up after months and months of fighting and couples counseling, it's heard differently and experienced differently because the context is different. So if I say to someone, if your heart stops, would you want CPR? They've seen glamorized versions of it on TV, like George Clooney running around in some ridiculous charade, and 80% of people on TV survive. When in reality, if you're hospitalized, the rate of getting a heartbeat back and leaving the hospital is about 15%, but that doesn't say anything about the neurologic condition you're going to be in. A lot of people don't know that. They also don't know that CPR begins at the moment of death. We are trying to reverse death. And reversing a death is not the same as restoring a life. That is verbatim something that I talk about with my patients
I'd love you to
because
say that again.
reversing a death is not the same as restoring a life.
And what you're putting a fine point on is that CPR is done when someone is essentially already gone.
Yep. And I talk to them, I ask them when I talk about CPR, tell me what you know about your medical condition. Because if they don't know, for example, that their cancer is metastatic and incurable, or their heart failure has significantly worsened in the last 6 months, and you don't tell them what that means, not just your ejection fraction is now 20% and it was 30%. Okay, but what does that actually mean? What are the implications of that? So I teach my colleagues, there's giving out a fact and there's explaining the significance. And if you don't explain the significance, how do you expect people to make informed decisions? So I will often take CPR off the table entirely and say, if you got to the point where your heart stopped and you died, it would be a result of the underlying incurable cancer. CPR would not reverse your death. It would extend your death. And we talk about suffering and dignity, but I only go there if I'm convinced people actually understand what they're going through. Sometimes it's more of a shared decision making where the path is not entirely clear, but even then, you need to make sure they understand. It's kind of like a surgeon coming in and saying, I'm sorry, but you're not a surgical candidate because the risk of you dying in the operating room or shortly after is way too high. In my opinion, if you frame it the right way and you're coming in with compassion and the best interest of the patient, and you say CPR is not something we're going to do, to me, it's the same logic as telling somebody you're too weak for chemotherapy or you're too weak to survive the operating room. But I think we don't think about this in the same way. And I don't think we are trained to be radically honest with people about
Sunita,
this and about a lot of things.
you raised so many good points. What you're describing essentially, whether you're talking about end of life, you're talking about deciding to take Lipitor for your
Yep.
cholesterol, you're talking about the ingredients for a compassionate, caring relationship that is centering the patient.
Yes.
You're centering the patient. You're not centering your fear as the doctor, your ego,
Yep.
your vulnerability about that person's death, your preconceived notions about what this person should do, or your own fear of being honest, which I think
Yeah.
happens all too often in medicine,
All the
particularly at
time.
end of life. So I want to talk about that in a second. But what you're describing is the optimal ingredients for the transmission of information from patient to doctor at any point of life. And particularly at the end of life, it is so important to have that, first of all, trust and rapport between you and the patient, right? Even if you have short amount of time you need to with your patient to get to know them, get to know the family, like, I know that you are an expert at establishing rapport, and that is an art, and that's not something we really are taught in medical school.
No,
It's an art. It's an absolute art, and that is, the privilege and joy of being a physician in my mind, but it's an art.
I
Um,
totally agree.
there's trust, and then there's also, as you said, the facts have to be there. And I sometimes see that the facts may be there, like, as you just said, the doctor, the cardiologist may have said your ejection fraction is 20%. That's essential information to know. But they have not gone beyond the facts. They have not
Yeah.
gone to the place where they say, "And that means that the chance
Yeah.
of death in the next 6 months is X."
And even this is what your life is going to start looking like.
Right.
Even apart from the chance of death, it's like, what this is the implication for your life. Tell me what's important to you. Because if these are the implications for your life and you're telling me you would never want, the
Oxygen.
indignity of CPR, or you wouldn't want an oxygen tank because you saw your dad carrying that around and you decided it's not for me. That helps us to figure out the next steps. Maybe the next step, if your EF is 20%, is not an implantable defibrillator. Maybe it's a decision to be do not resuscitate. I actually don't like that term. I like the term allow natural death, which to me kind of implies an unfolding rather than a withholding. And so that is really important that, okay, your EF's this now, but here's what your life could look like. So I think we don't know how to do that. We don't know how to sit and witness suffering. We don't know how to be uncomfortable in medicine.
I think you're
Uncertainty and
right.
discomfort, we can't deal with it because we want to know the answers. We want to fix the problem. But even from that perspective, when I was a resident, I was on call for the cardiology service at San Francisco General, and it was just me. It was nuts. I was like, how am I going to do this? And that night, I had two patients come in within an hour of each other. Both randomly were Vietnamese men. Both had heart attacks with blockages in the same artery. They both had the same medical history and they were the same age. I did the same thing for both of them. One lived and one died.
Wow.
So, how do you square that, right? Like, we're not good at sitting with the discomfort of not being able to answer that question, or the question of, why did my guy with metastatic colon cancer lived for 4 years and another guy who was actually healthier than him died in 6 months? We don't know how to sit with that. We don't know how to witness the suffering. And in order to have these conversations, you have to create a little space to be uncomfortable and to be honest with yourself. And I tell my trainees 95% of doctoring is an inside job. Like, you want to learn, what is it about my reactions and the way I'm handling things that can influence my conversations? Am I being authentic? Because people want to feel like they're talking to a real human being. And it's okay to be authentic. I think my authenticity was trained out of me. And in the third year of residency, I was like, screw this. I'm going to be myself. I mean, not like all myself, but like just more relatable and down to earth, and not like breaking down that barrier of feeling like I can't be affected by these people, or I have to remain at a distance and ignore my own emotions. And people, they know when you're being honest. They know when you're withholding something. And
100%.
they want the truth. And I'll tell them sometimes in really hard conversations, I would rather tell you an ugly truth than a pretty lie. The pretty lie helps me more than you. And that's not
Right.
what we're
I
here
think
for.
there's so many great points you're making about medicine and doctors. The way we have set up our system is that it's interventionalist, it's transactional, it's fix the problem at all costs. Um, I really like the notion of flipping the "do not resuscitate" language to allow natural death,
Yeah.
because it seems like semantics, but it's actually not. I mean, death is inevitable, right? Death is natural in every way. Our job as doctors is to help prolong life. It's really, though, to improve quality of life.
Yes.
So, I mean, that's what we're talking about in the first place here is we're talking about quality of life and quantity, but we're talking about the quality of life, particularly at the end of life. So when you decide to intervene, say with CPR or with just heroic measures, antibiotics for someone who's septic in an ICU, you're deciding to fix that problem, but you're also creating another problem, right?
Yes.
Every solution has a downside, right? There's an
Exactly.
unintended consequence of every intervention. And if we're centering as physicians, we're centering our desire to fix, our desire to cure, our inability to sit with discomfort, then that is harmful. That is doing harm.
Yes.
So, I think the best thing you can do if you're new to this as a physician, and I know that not this is mostly not physicians listening, but is to acknowledge to the patient, like, I have an anxiety about, you know, not wanting to hurt you and wanting to help you, and here's what I know, and here's what
Yep.
I think, and here are the trade-offs of the situation we're in. And just
Totally.
being honest about what you don't know, I
Yep.
think that is what breeds trust, right?
Absolutely. I totally agree with that. And I think, again, we're not really told that we can be honest with people.
Right.
This is why we delay these conversations. This is why people suffer and wish they'd known certain things sooner because they would have made different decisions. And like if I'm in a family meeting and oncology is there and the family and the patient are there, sometimes I'll prompt the oncologist and say, Dr. So and so, what are your thoughts on how this chemo could improve his life and how do you think it might impact his life negatively? So I'll prompt to get them to say things. And if they're saying things that remain unclear, then I say, here's what I'm hearing. Here's what I'm confused about. So that sometimes families don't feel like they can challenge or question a doctor. So I put myself in that role in some family meetings which I think, because it's coming from a good place, I want them to be
Well, of
able to say
course.
these things.
Of course, you're trying to, and they don't know what they don't know, right? So you are hearing the I mean, I do this too, is I am in touch with my oncology. It's usually the oncologist, and I love my oncology colleagues, but they often treat the cancer and not the patient.
Yeah,
I'm not saying uh, that it's always the case, but I think it can be hard when you're in oncology to step away from treating every last tumor cell. If that's what the patient wants and they know what the options are and they know what the facts are and the consequences of the treatments, that's one thing. But if they aren't given the facts, the truth, and the consequences of the
yeah,
treatment, and they don't know that the option is something else, they're not going to think to ask of it. So it's an act of love. Again, I do believe it's an act of love that you're giving
yeah,
patients a broader aperture on the conversation,
totally.
and then more options and more agency, because we're talking about
Yeah,
agency at this point.
yeah. I've been thinking a lot about the word mercy. I
Mm,
used it earlier, but it has religious and spiritual connotations, but I really think it's a powerful word.
it is.
And I think in addition to honesty being an act of love, it's an act of mercy. And I think that is ultimately what medicine has always been about is mercy in one form or another. Recognizing what we can't fix and being honest about that, witnessing the suffering that is inevitable, and doing what we can to make things better. And cures that we've come so far with our treatment of surgeries, OBGYN, safer deliveries, safer surgeries, antibiotics that can cure, a number of infections. And that is all thrilling and important. And those are also acts of mercy, in my opinion. And so that word has become really resonant with me recently, and I'm using it a lot more in family meetings. And you can think of other human concepts that we don't talk about in medicine, like
I was about to say
dignity.
it's very human, the word mercy. It's very human, it's emotional. I feel a New York
Yes.
Times op-ed coming for you, Sunita, titled, like, "Mercy as the best prescription," or something less cute than that, but mercy implies a shared humanity. a
Yes,
transmission of power from one person to another, even in their darkest and most vulnerable moments. And that's ultimately what doctoring is about, right? Not to
absolutely.
be, overly kind of, eh, I don't know, woo woo about it, but at the end of life, in particular, there's no kind of like golden path. There's no certainty, and so basically, you're just trying to give someone a sense of agency, which is ephemeral at the end of the day.
Yes. And helping them to become a little more comfortable with uncertainty.
Yeah.
I think that's a huge part of what I do for patients is hold them in their uncertainty. And we do other things like treating pain and nausea and all of that, having goals of care discussions, but when you're like with somebody who is just anxious, anxious about what's coming next. You validate the anxiety, but you also go to, how have you handled uncertain situations in the past? What's worked for you? What
Yep.
hasn't? This is that situation on steroids, but maybe we can find a way to cope with this in a way that gives you a little more peace. I'm not saying that the uncertainty is going to go away and you're not going to feel anxious, but I would rather instead of medicalizing this and prescribing something that will help you with anxiety, I'd rather get to the root of it and sort it out a bit with you and refer you to a really good therapist or social worker outpatient because I don't see people outside the hospital right now and continue that work because as you said earlier, dying has become medicalized. Dying is not a medical event. Dying has emotional and spiritual and religious connotations, and it always has. And well before Western medicine became a thing, people were dying, and it wasn't about Western medicine at all. So, kind of being present for them in that way and saying, this is very uncertain territory. This CT scan could show something really challenging, but on the other hand, the uncertainty also allows us to hope for something better.
Mm.
You just because you're fearing the worst does not mean the possibility of good news is out of the question.
Sunita, let's talk about people who are listening or people in general who aren't at the end of their life. Maybe they've had some bumps on the road, a serious diagnosis here and there. Maybe they've witnessed the death of a loved one, and they're thinking to themselves, "I want to think ahead to when that time comes for me."
Yeah,
So this is a conversation I have with patients not infrequently. And the conversation that I was taught, probably like you in medical school, was to basically go through a checklist.
yeah,
I want CPR. I don't want a ventilator. I want a feeding tube. I don't want to. It's like going to In-N-Out Burger, or
yeah.
right,
I
just
have
like
a line in
I'll have
my
fries on the
yeah.
side. It's
I
like
have a line.
yeah, it's like a checklist, a transaction, which, as you said in the beginning, it's like very transactional and has no context. So what I try to do, and I know you do too, and I want you to hear about how you do this, is talk to patients more about why they're alive in the first place and what quality of life factors, if they were to go away, would not be acceptable to them.
Yeah,
And then you decide on the trach or the feeding tube based on whether or not that intervention would allow them to go to their grandson's baseball games, would allow them to listen to Mozart, would allow them to be ambulatory or have speech. And if that intervention wasn't going to help them with those things that gave them quality, then you choose against it. But that conversation is not happening in doctors' offices. I barely have time,
yeah.
even though I make time for it. So how do you suggest people, the average mortal walking around, plan for their death?
Yep, that's a great question, and I do just wanna mention another line from my CPR piece because this was,
Please.
like, my favorite line to write. Actually, there are 2, but, um, I talk about exactly this, like, people who want CPR but not ventilation, or people who want chest compressions and no shocks, and I refer to it as a Burger King code.
Right.
And just like it's like whatever burger place you're into, um, that's not how this needs to be approached because it's not like, do you want bootcut jeans or straight leg jeans? But it comes off like that.
Right.
So I think there's a lot I want to say on this question you asked about how people can start to think about it. One of the things I really suggest as a form of introspection is think about people you know who have died and ask yourself, how did they die? What was good about their death or acceptable or comfortable, and what made it really hard for them or their family? And ask yourself, he was on a ventilator for like weeks and weeks, and then he ultimately died. And I don't know if I want that for myself. Or on the converse, he was on a ventilator and trached, and no one thought he could make it, but he made it 6 months later. And when people say that, I'll then ask, what does making it mean?
Right.
What does that look like? Because when people tell me, when we start talking about these things, I'm a fighter and I want everything done, my response is, tell me what you mean when you say you're a fighter, and what does everything mean to you? These are very elastic words. They're all coming from some flawed medical TV show script or something, but we all use them. And then we get afraid. Oh, he's a fighter. I've got to do everything. But you don't actually know what that means.
Right.
And like, we don't know what people mean when they say they want everything done. So I think a part of it is getting people to reflect on the deaths they've seen or the suffering they've seen,
Mm.
the indignities that they've seen, and then asking them to think about if they were in a similar position, what might be important to them. I find that is a really good way in because it's
It sounds
linking
like it
their
is.
life to
It makes it
their,
it also concretizes it, right? It makes it
yes,
more tangible. Because if you're sitting in a doctor's office, like in a primary care office like me, and you're feeling generally pretty healthy and it's hard to think about what your death would look like
exactly.
without referencing some other. So I think that's a really good, piece of advice. What else do you recommend to people?
The other thing I recommend is really think carefully about who you want your surrogate decision maker to be if you
Mm,
can't make decisions for yourself. And the reason I say this is because I've seen a lot of situations where, for example, a wife doesn't name her husband as the decision maker because we've talked about it. And she was like, he would never let me go. So sometimes the best people to act on your wishes are not the people closest to you. So it doesn't have to be automatic, like, oh, my spouse has to be the decision maker or my child has to. It could be a friend who's known you since kindergarten, who
mm,
really gets you. So I ask them to think really deeply about that and about people they would not want involved in decision making, because sometimes the relative flies in from wherever and has not seen this person in years and then upsets the whole type of decision making that we were working towards. So
yeah.
I think that's really important. And I think validating that these are choices for now. Things are going to change and we will stay in converse. Any trigger that happens that can reintroduce a conversation. So things like getting hospitalized for a heart attack, having had a stroke, especially when it's out of the blue and unexpected for like a 49-year-old or
Right.
something. Using that or having to move to a nursing home. That to me, any transition is a good time to bring it up again and to say, last year we talked about this and a lot has happened. Can we revisit this? Because I think your body is trying to show us something. And I think we need to have a conversation about that and put it in again in context and reference past conversations. I'll also reassure people that, like, it is okay to change your mind. Once you write things down, you can still change those things. Because I think sometimes people say, like, I know doctors who say, I would never want CPR, I would never want chemo. But sometimes I tell them, you don't actually know until you're there.
Yeah.
What if it was chemo for a totally curable cancer?
Right.
What if it was CPR for one of the reasons CPR was actually invented for
Right.
an
Like,
acute
you
reversible
choked on a
problem?
grape or something in a restaurant. Like, yes. What about, people who are listening to this and they say, "Well, okay, I like the idea of revisiting this, but I can't hire a lawyer every time I have a new medical event."
Yeah,
Like, where are you recommending they document this? Where are you recommending they and not everybody has a doctor who's gonna talk with them about this kinda
yeah.
stuff. So where are they documenting this? Who are they telling it to?
So a lawyer is not helpful
Right.
in these situations because they can't counsel you. I feel pretty strongly it needs to come from the doctor, like in the context of a medical relationship. Um, There are most hospitals have advanced care planning forms, and there are POLST or MOLST forms in many
Yeah.
states. So, physician order for life sustaining treatment, also known as a medical order for life sustaining treatment. And it goes over some basic
Yeah,
choices like,
it's the MOLST form,
yes.
and you can print it out online. If you're new to this whole conversation, you can print out the MOLST. It's just a basic template.
Exactly. And I think having that on file in your medical record and putting it up on your fridge where it's meant to go in case there's an emergency, you can't make your own decisions and EMS shows up. They are obligated to follow what is on that post. And so, in the absence of that, they're just going to do everything. So, if you don't want those things done, then definitely get a post or a MOLST. I'm not saying things like living wills aren't important
Right,
and going through your lawyer is not something you should do, but you want things on record in your medical center because you don't know when things are going to change.
right,
And so, with that uncertainty comes the importance of planning. Because the other thing I'll tell people is I know this is really scary, but it's an act of love for the people in your life.
right,
Because, and honestly, it's an act of intimacy. What is more intimate than talking about how you want to be cared for as you're dying? So I try to reframe it and make it a little less scary. I validate that it's hard to talk about these things, but if you don't, we may do a bunch of stuff to you that is not appropriate because our default is just to speed down the highway of technology. And if you can use this as an opportunity to be honest with the people you love, it only deepens love. It deepens other things too, but it does deepen love. And sometimes I'll tell them, like, me having this conversation with you is also an act of love. Like, I care deeply about you. Even if I've known them for like 3 or 4 days in the hospital, if that feels true, I say it.
yeah,
Because sometimes you immediately bond with some people, and it's okay to say that, like we were talking about earlier. Those are the big tips that
yeah,
I have. And I think the other advice I would give people is if your doctor is not having this conversation, ask to have this conversation and tell them why. Like, hey, my sister just died of a massive heart attack and her death was awful in the ICU. I'm thinking about my own death and I want to talk about my choices.
yep, and
Can
don't
we
bring it
have
up
that
when you're going
conversation?
and don't bring it up when you're going in for, like, your cholesterol check or something. Make
Yes.
a separate appointment and, bring ideas with you about,
Yep.
the death you want, the death you saw in another
Yep.
person, what your sort of North Star is in terms of why you're alive. I mean, there is this opportunity for self-reflection, like what
Exactly.
makes what gets you out of bed in the morning? What gives you meaning and purpose? And what are the sort of what are the quality of life elements that if they were taken away would characterize a life that you did not want to live?
Exactly. And I think sometimes doctors will try to pawn you off to someone else, like a social worker. And it's not that that's not an important supportive space as well, but you want your doctor to be honest with you about what's going on with you now and what these choices mean. And social workers, while wonderful, are not medical clinicians. And
Right.
so they can't really talk to you about, well, you have metastatic cancer and this is what it means if your heart stopped.
Right.
So I think making it clear you want to talk to your doctor about
I
this.
think it's a great point. I think it's a great point. I think also, um, just to put a fine point on it, it's not that you and I are asking doctors to predict the future or to give percentages and data that we don't know. It's really just
Exactly.
a framing of where they are in their disease, and if you're totally healthy, great, but if you're talking about where you are in someone's disease trajectory, giving someone a sense of the contours of what life might look like for the next 5, 10 years, 5, 10 months.
Exactly.
Someone's asking me here, Sunita, about anxiety and death. And I think it's a really, really good question and point. We were talking about how you and I were talking about earlier how you don't want to make the mistake. I don't want to make the mistake. I don't want doctors to make the mistake of medicalizing someone's anxiety, natural anxiety about dying by over treating them, by giving them too many, treatments without talking about the anxiety itself. neither you nor I are saying that's to ignore the anxiety. It's really to honor the anxiety. And
Exactly.
it's also not to say that having anxiety during the dying process yourself isn't normal, isn't something we can treat with medications in tandem with the holding space for the uncertainty and the vulnerability. In other words, yes, you can treat someone's anxiety. I mean, we have short-acting, long-acting medications that are wonderful to help people with the existential despair and anxiety of dying. But I think what Sunita is saying, correct me if I'm wrong, is that to not hold space for the anxiety itself and to treat it with, CPR and aggressive interventions without having the patient understand that, let's talk about the anxiety itself is to deprive them of, to me, options, agency, and
Yep.
humanity.
And I want to mention another therapy, which is psychedelics, because
Let's talk
with
about
death
psychedelics.
anxiety, yes, with death anxiety in particular, we have studies from randomized clinical trials, which is the gold standard in medicine, where people with advanced cancer were under controlled conditions given a certain dose of psilocybin and taken through a psychedelic experience with it. And they were working with trained guides because you need a guide if you're going through this experience. And their death anxiety drastically dropped. And I encourage people to look at those studies because psychedelics are not yet legal in our country, but there are plenty of people taking folks through ceremony. And I I have found with patients who have severe death anxiety, I have sometimes prescribed ketamine, for
Mhm.
example, which
Yep.
will help with anxiety. And, it's used in many different therapies, trauma therapy as well. And, but I don't do it unless I feel like they are getting sufficient support in the form of talk therapy. I do think some deep depression, anxiety, trauma, some of that does not respond to talk therapy, and you really need to have a bodily experience, which psychedelics enable, and they can be transformative for people for many different situations, but we have data on death anxiety specifically.
Yeah, the data are pretty clear. I mean, I think people think of psychedelics as outside the box, but they're
Yeah,
probably more inside the box than a lot of the traditional psychopharmacological tools we use. They're more elegant for death anxiety, PTSD. For people who don't know what the heck we're talking about, we're talking
yeah,
about psychedelic, naturally occurring medications, in some cases like psilocybin, which is known as magic mushrooms, but it's that needs a rebrand. If you're interested in what we're talking about, I did a podcast with Paul Thamby and Manish Agarwal like a couple of years ago. It's on this podcast, talking about their work in oncology. They were both
hmm,
oncologists who recognized through their training they were treating the patient and not sorry treating the cancer and not the patient.
yeah,
And they were just morally injured from watching people die without dignity. So
yeah,
they got very interested together in the art and science of psychedelics to help people sort of find a more spiritual and like acceptance and peace around dying,
yeah,
which is arguably more safe than like taking Xanax, if it's done right with the right
yes,
setting, the right guide. But if you're interested, there's a really great documentary called "How to Change Your Mind" about the psychedelics of the landscape. It's all tangled up in FDA regulatory stuff right now, but I do hope that someday, Sunita, we have the ability to recommend those kinds of life-altering substances in the right moment for patients, particularly at the end of their life.
yep. I totally agree. And I think it's also important to recognize outside of a setting where somebody has expertise in being a guide,
Right.
people can have bad experiences. And so
Absolutely.
it's really important if you're going to do it to go to someone experienced.
That's
And
right.
I've had people call up Johns Hopkins and NYU and just ask who worked on this clinical trial and, or email them. And they have, according to my patients, been able to get in touch with people. It hasn't necessarily led to finding the right guide, but try to go to reputable sources.
Right, absolutely, and again, it does seem like outside of the box and kinda woo-woo to people, but I think you know, the data are pretty darn clear that
Yeah.
for death and dying and for other clinical scenarios where people are looking to have a deeper, more bodily, spiritual experience of acceptance, it can be transformative.
Yep.
Um, so I think what I'm hearing from you, Sunita, is that medicine in its current incarnation in this country is failing people at the end of their lives. We tend to medicalize death, and you and I are not against, of course, chemotherapy, aggressive measures in the right context. It's if the patient wants that and if they are given the menu of options and told what the facts are about their
Yep.
situation. And that we need individuals, people listening, and in general, to understand what a good death is, that is possible, but be realistic about it.
Yep.
And I liked what you said about recognizing that good death isn't necessarily what you see in the movies. It can be a beautiful death in an ICU. It can be a beautiful death in a hospital setting, and there are actually some benefits of that.
Totally.
My brother, I told you last year, I'm not gonna talk about it too much because 'cause it'll make me weepy, but my brother died suddenly last July, and it was the most beautiful death in an ICU. It was a
Yep.
sudden accident, it was horrendous. 3 days we held vigil, and it was a beautiful death, and it was possible. I didn't think it was possible in
Exactly.
ICU.
And I
Uh,
think we give the ICU and this and the hospital, like, we have an image of it as being just devoid of dignity. And yet I feel like with some of my patients, if I had sent them home, that would have been undignified for them.
well, and you talk about anxiety about the for the patient side, the anxiety for the family and
Yes.
is it can be enormous, and I felt like the team that my brother had in the ICU was extraordinary.
Yep.
Medically, but also just from a human standpoint, it was extraordinary. So and then you also talked about what to think about when you're thinking as a healthy person or someone who's not at the end of their life in a hospital right now, about how to frame the conversation with yourself and with your doctor about what
Yep.
your wishes are.
Yep.
Not by thinking about a Burger King takeout menu, I want CPR, I want a peg, I want a feeding tube, but rather thinking about what you're alive for, what kind of deaths have you seen that seemed acceptable, what was not acceptable to you, and just having those conversations and then revisiting those
Absolutely.
conversations.
Of course. Yep.
And then
And I
also being willing to, and this is hard as a human being, right? To sit with uncertainty and sit with anxiety in your regular life. I mean, this is
Yep.
sort of it's a hard thing for doctors as a cohort of people. We don't like uncertainty. We like to fix things. And I can say for as a person who loves to fix things and problem solve and, tie things up in a bow, sitting with uncertainty, sitting with vulnerability, sitting with the fact that there are no good answers in certain
Yep.
areas of life is exquisitely painful, but also exquisitely important to do when you're alive.
And I think that's some of the spiritual work of being
That's
a
right.
human being. I think the other concept, in addition to uncertainty, is the idea of impermanence, which comes very strongly from Hindu and Buddhist traditions. But this idea that everything in life is subject to change. The only thing, and I'll tell my patients this sometimes, that we are not our bodies. What's happening to you is not your fault. You are bigger than the body you live in. And I straight up tell them that, and those turn the conversations
Mm.
because, again, you're going back to concepts of who are we really? Like, that soul could have showed up in anybody, but he would still be that soul. This body is dying, but that doesn't mean you are dying. And if that resonates with people, I've found that it really brings things to like an open field. And the idea of impermanence and getting used to that is something that every person I think should start to meditate on. Because think about it, like if you just look outside at a tree, that tree is going to lose its leaves. They're going to become beautiful in Burgundy because you're on the East Coast, and they're going to desiccate, fall, and be crunchy under our feet. the trees are going to be bare for winter, and then you're going to start to see the green come back. That cycle defines impermanence. So it's an easy place to start, to just contemplate that. And then to think about like relationships in your life that have been there but significantly changed. That's because nothing stays the same, whether it's the tree with the leaves outside or your relationship with a spouse or a relationship with your friend. It's all fleeting. And I think the more we start to really accept that, the more we can find joy in what we have. Because I was thinking about this the other day, and I'm going to try not to get weepy, but I've never had a dog before. And 6 years ago, I adopted my German Shepherd mix, who was sitting here, but I don't know where he went. And I think about what it will be like to lose him, which is going to be, I don't even want to get into that, but I do realize that every time he sits next to me when I'm writing, that is such a gift because in a moment it's going to be gone. He's going to go run after my cat. But just sitting with the notion that this moment is precious and what comes next, who knows? But also what comes next could be a really good thing, not just the bad thing.
Well, that's it, and I think it's a good place to end here, is that, I think when you think about death, it seems like a gloomy topic. It seems like a depressing topic, when actually thinking about death is a way of thinking about life, right? Thinking about dying is a way of thinking about living. And there is beauty in unexpected places. There is, like, I never thought that seeing my brother die would bring a sense of beauty into my life. Like, who knew?
Yeah,
So,
totally.
I mean, and I'm gonna get weepy too, but I'm just saying that, like, there's life is so unexpected and so uncertain, and I think you have said it so beautifully. I hope you keep writing, Sunita. I think we need,
Oh,
like,
yeah.
I mean, I know you will, but I think I want to give you a megaphone. I think we need, like, 10 of you in every hospital, and we need more training of doctors to be able to have the
Yep.
conversations you're having one at a time because it's one of the more sacred moments of life is death, and I think that to give someone the gift you have of that communication, that transmission of trust and love is pretty amazing. So, please keep writing,
Thank
and I
you.
can't wait to see what you publish next, and thank you so much for joining me.
Thank you so much, Lucy, and thanks to the audience for showing up.
Okay, bye, Sunita.
Okay, bye.